Before we dive in, please do three quick things. Subscribe to the channel, like this episode, and comment with the next community medicine topic you want. Done? Awesome. Let's roll. Welcome to episode 6 of Case-Based Scenarios on Family Planning and Contraception. Today, we'll tailor counseling to the life stage from immediate postpartum choices to special medical histories and keep it exam-ready. Dr. Joshi, thanks for joining us.
Glad to be here. Keep two anchors in mind. India's National Family Planning Program basket, condoms, combined pills, the weekly non-hormonal pill Centroman, brand Chhaya, injectables under the Antara program, depot-medroxyprogesterone acetate, intrauterine devices and sterilization, and timing rules for the postpartum period, including the postpartum intrauterine contraceptive device.
Scenario 1. A 23-year-old has just delivered her first baby in a tertiary center and asks for contraception before discharge. What are the choices for a postpartum woman and what are the criteria for PPIUCD insertion?
Postpartum choices, organize them by now, soon, later. Now, that is, before discharge, PPIUCD, copper IUCD, inserted immediately post-placental, that is, within 10 minutes of placenta expulsion, intracaesarean, placed at the fundus before uterine closure, or within 48 hours after birth. Avoid if there is chorioamnionitis, rupture of membranes more than 18 hours, or unresolved postpartum hemorrhage. Condoms start anytime. Lactational amenorrhea method, LAM, if she plans exclusive, on-demand breastfeeding, is amenorrheic and the infant is under 6 months. With all three criteria, effectiveness approaches about 98% in the first 6 months. Soon, that is from 6 weeks if breastfeeding. Antara, that is depot-medroxyprogesterone acetate, 150 mg intramuscularly every 3 months. Breastfeeding women start at 6 weeks. Typical use failure is low, about 0.3%, and counseling should anticipate irregular bleeding or amenorrhea. Progestin-only pill can also start from 6 weeks postpartum if breastfeeding. Program specific. Later, that is once lactation is established, often after 6 months if breastfeeding, combined oral pills as per medical eligibility and preferences. Centroman or Chhaya, a weekly non-hormonal pill, can be started in breastfeeding women. Program materials note it does not affect breast milk. Follow the twice weekly for 3 months, then once weekly schedule, and ensure she is not pregnant when starting. PPIUCD criteria, think ACT. Adequate counseling and consent antenatally or intrapartum. Clinically eligible, no infection, no unresolved hemorrhage, membranes not ruptured more than 18 hours, no extensive genital trauma, timing, postplacental, intracaesarean, or within 48 hours. After 48 hours, wait until 6 weeks for interval insertion. Pause and recall. After 48 hours postpartum, when can a copper IUCD be inserted? Answer: at or after 6 weeks, interval insertion.
Scenario 2. Ritu and Akash have a 4-month-old who is exclusively breastfed. They want spacing. First, which methods suit them now? Second, which are unsuitable and why? Third, explain the mechanism of LAM.
I. Suitable now in the scenario of baby 4 months, mother amenorrheic and exclusively breastfeeding. LAM, lactational amenorrhea method, meets all three criteria. Condoms for dual protection. PPIUCD, if not done earlier, she can take an interval IUCD anytime after 6 weeks if pregnancy is reasonably excluded. Antara, that is DMPA, from 6 weeks postpartum if she chooses an injectable. Centroman, Chhaya, weekly pill may be offered. Program material state it is compatible with breast milk. 2. Less suitable or currently unsuitable methods would be combined oral pills in early breastfeeding months. Many programs defer COCs until around 6 months to minimize any effect on milk. Use when breastfeeding is established and medical eligibility is met. Emergency contraception is for occasional use only, not a spacing method. 3. Mechanism of LAM. Frequent on-demand suckling suppresses the hypothalamic pituitary ovarian axis, reducing gonadotropin-releasing hormone pulses, so ovulation is inhibited. LAM is valid only while all three hold: exclusive or near-exclusive breastfeeding day and night, amenorrhea, and infant less than 6 months. Once any criterion fails, even one night feed dropped regularly, switch to another method. Pause and reflect. What are the 3 LAM criteria? Under 6 months, Amenorrhea, exclusive on-demand breastfeeding.
Scenario 3. A young couple seeks advice. The wife had an ectopic pregnancy 2 years ago, and now her blood pressure is 160 over 90 millimeters of mercury. What will you suggest and why? What is contraindicated, and how do you deliver a cafeteria approach counseling?
Start by applying medical eligibility. Hypertension at 160 over 90 is severe, so combined hormonal methods, pills, patch, ring, are contraindicated. Progestin-only methods are generally safer than combined ones, but depot-medroxyprogesterone acetate is often less preferred in severe hypertension. Non-estrogenic long-acting reversible contraception is preferred here. 1. We can suggest copper IUCD, which is highly effective, category 1 for hypertension, and acceptable with past ectopic. Overall ectopic risk is reduced because pregnancy itself is rare. Levonorgestrel intrauterine system, if available and desired, offers very high efficacy with first-year failure around 0.1 to 0.2%. Avoid only if there is current breast cancer or severe liver disease. Progestin-only pill can be considered, no estrogen. Barrier methods as backup or if she prefers. 2. Contraindicated or contraceptives to avoid. Combined hormonal methods, estrogen-containing, contraindicated at this blood pressure level. Caution with depot-medroxyprogesterone acetate in severe hypertension. Many references recommend preferring non-estrogenic but non-injectable or intrauterine options here. 3. Cafeteria approach. Explain all suitable options neutrally, compare effectiveness, side effects, reversibility, return to fertility, visit frequency, screen with eligibility, then let the couple choose. Summarize with the decision and a return or what-if plan, missed pill or warning signs, and document informed consent. Self-check. Which long-acting options avoid estrogen and suit severe hypertension? Answer: copper IUCD and LNG IUCD.
Scenario 4. A woman with a 3-year-old comes for an IUD but is worried about side effects. Mention the effectiveness of third-generation IUDs, assess if she's an ideal candidate, and list absolute contraindications.
Third generation usually refers to levonorgestrel releasing intrauterine systems. First-year failure is roughly 0.1 to 0.2%, comparable to sterilization. Copper IUCDs like CU380A are also top-tier, with less than 1% first-year failure in typical use. Quote these to underline effectiveness. Ideal IUD candidate, quick checklist, wants long-term reversible contraception, no current pelvic infection, no unexplained bleeding, low risk of sexually transmitted infections, mutually monogamous, no distorted uterine cavity, willing to return for follow-up and to check strings. Absolute contraindications to IUD insertion would be pregnancy, current pelvic inflammatory disease or purulent cervicitis, puerperal sepsis or septic abortion in the last 3 months, unexplained vaginal bleeding suggesting malignancy, known or suspected genital tract cancer, distorted uterine cavity, for example large fibroids, and known Wilson's disease, or copper allergy for copper IUCD. For levonorgestrel systems, add current breast cancer and severe active liver disease. Counseling to address apprehension. Explain common, usually self-limiting effects, cramps, spotting initially, very low perforation risk with trained providers, and the rapid return to fertility after removal. Pause and recall. What 2 absolute, timing-related contraindications uniquely matter for postpartum IUCD? Answer: chorioamnionitis and rupture of membranes over 18 hours, also unresolved PPH.
Before we close, could you give a rapid comparison?
Sure. Postpartum offer PPIUCD, condoms, LAM, and from 6 weeks if breastfeeding, Antara, DMPA, or progestin-only pills. Consider Chhaya weekly pill with counseling. For spacing at 4 months breastfeeding, continue LAM plus condoms. Add interval IUCD or Antara if desired. For severe hypertension with prior ectopic, choose copper IUCD or LNG IUCD. Avoid combined hormonal. Be cautious with DMPA. IUD facts. Approximately 0.1 to 0.2% failure. CU380A less than 1%. Absolute contraindications as listed. Final active recall drill. 3 LAM criteria are exclusive on-demand breastfeeding, amenorrhea, infant under 6 months. 2 PPIUCD exclusion conditions are chorioamnionitis and membrane rupture over 18 hours, also unresolved PPH. One top-tier option for severe hypertension is copper IUCD. First-year failure of levonorgestrel IUCD is about 0.1 to 0.2%.
Perfect. Today we walk through postpartum choices and PPIUCD criteria, breastfeeding-friendly spacing, special counseling with hypertension and ectopic history, and IUD effectiveness and safety. If this helped, remember to subscribe, like, and tell us what topic you want next.